So I just really want to talk about how to examine the rotator cuff, thinking about it as four different unique parts: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, just like you do when you examine the knee or other places and you're looking at the various joint ligaments. The supraspinatus examination, if we go back and just think about it, this is what we're trying to see. The supraspinatus is over the top. You see how that infraspinatus wraps around, which is why it is an external rotator. The teres minor is down low. That's why it primarily works when the arm is in abduction. And the subscapularis is coming at an angle, which really helps to depress the humeral head and helps support the internal rotation. And we're all very well aware of the Job test. It's been used for many, many years. And the empty can, which people have argued is kind of a tough test because it puts the arm in a provocative position. And if you have impingement or bursitis, you get a weak shoulder. You can't really tell if there's something wrong with the rotator cuff. And so it's been really the de facto test for many, many years. But there's other tests like the Hawkins test and the full can test and things like that. My partner, Greg Nicholson, challenged to us to think about whether there's other ways that we can look at the rotator cuff, and came up with this idea of the champagne toast test as opposed to the Job's test. And what we did is we did some fine wire EMGs and some surface EMGs, and we looked at all the different muscles. And then we tested it and tried to see where the greatest signal was in the supraspinatus with the lowest signal in the deltoid. In other words, tried to find the largest ratio difference so that we could really tell what was going on in these different areas. And we were able to really go through this and look at the different things. So what you see with the Job's test, it does test the supraspinatus, but the deltoid is highly active throughout the entire process. So it's kind of hard to separate those things out. When you look at the champagne toast test, this is one where you put the arm as if you're holding a glass of champagne, and then the examiner puts their arm on the lower part of their arm, and you ask them to elevate their arm, and they put it in that position. What we saw is it really made the deltoid much more silent in this position, and the supraspinatus was still very active in that position. And the ratio was dramatically different between the Job's test and this test. So the best ratio of supra to deltoid was the champagne toast. The worst ratio, in fact, was the Job's test because there's so much deltoid activity. So we use this test, and I'll show you how to do this in just a minute. Now, the infraspinatus, this is a nice little thing that Alex Latterman put together. We did a symposium over in Europe this past year with regards to the SESIC meeting to go over all these things. This is the primary external rotator of the humerus with the arm at the side. It's about 60% of that strength, 22% of the overall strength. And the way that you examine this, you have to keep it down by the side. When patients have a weak external rotator, the first thing they do is they abduct their arm. What are they doing? They're engaging their deltoid and stabilizing their shoulder with their deltoid, and then they can use it for resisting external rotation. So have them keep it close to their side with a little bit of forward elevation and then test their external rotation strength, and you'll be able to pick that out. The other way to do this is that you can put the arm in a position where it's close to its end range and bring it in just a little bit, and then you let it go. And when it falls back 10 degrees or more, that's a positive lag sign. So here's an example of that where you did that. And then here's one where you just have them resist your movement towards internal rotation throughout the entire movement. And that's hard for them to hide that whole thing with their deltoid. So the arm is taken out to this position passively and tested, and then we maintain it in that position and see if they can do that. And if it drifts back 10 degrees or more, that's usually a good sign that something's not right in the back of the shoulder. And here's just an example of that where they can't hold it there. So it can be very subtle, but quite helpful, and it doesn't seem to hurt them very much. And this is just an example where the lag test was minimal on his examination. So test your external rotation about 20 degrees of abduction. Now, I'd like to have Steve Burkhardt come up to the front of the room, and Bill, if I can use your microphone. So again, for supraspinatus, a lot of people do this, but that could be very provocative. So I think if you try this test down in here, you might get a little bit better separation of your deltoid. Infraspinatus, keep the arm close to the side, slightly forward elevated, and then have them resist external rotation and do the lag sign. The one that many people either forget or don't know how to do very well is the subscapularis. So I figured I'd ask one of the masters of that to show us how he examines the subscapularis. So there's three tests that we're all well aware of. It's the lift-off, the belly press, and the bear hug test. So Steve, tell us how you use this to evaluate the subscapularis.
Yeah, so for the longest time all we had was the lift-off test, and the problem with that is you have someone try to lift their hand off their lower back, And if they have a torn subscap, it usually hurts to get it there. And so it's, first of all, it's hard to get them there. Second of all, they can cheat on it. They can put it right here, and they can just extend their elbow like that. And you say, oh, that's a negative liftoff, but actually they're cheating on it. They're not really using their subscap because they don't have it in the middle of the back. Then the belly press, for the way I do it is, and I think the best way is, I really shouldn't be able to lift anybody's hand. Of course, Tony, I couldn't do it anyway if he had a big subscap tear, but I shouldn't really be able to lift anybody's hand off their belly. So you can take like a lady that's much smaller than me, would be much weaker than me. I shouldn't be able to pull her hand off her belly. So just hold it there, Tony. And so I'll just try to pull their hand off their belly. And I shouldn't be able to do that. And if I can, then that's a positive belly press.
So what I always see the patients do is they do this. So
Yeah.
how do you coach them to make sure they keep their elbow
Yeah.
in the plane of their body? Because they always want to do this and cheat.
I bring their elbow out. In fact, Andreas Imhoff has talked about the Napoleon test. That's another one that they'll try to pull their hand back, but they'll use their posterior deltoid to pull back with their posterior deltoid, and that's not indicative that they have an intact subscap. Now you can get a false positive Napoleon though if you have a stiff shoulder, and if you just say that you have an adhesive capsulitis, they can't internally rotate enough to get their elbow out there, so that's one case where you can have trouble doing it. But so a positive belly press would be one where, Tony, just kind of give way on this one. So I'll pull the hand off and it just comes right off. Or maybe it doesn't come off real easily, but it's much weaker than the other side. I always test the two side to side. And then the other one that is one that Joe DeBeer and I described a few years ago is where it's the bear hug. You put your hand across to the opposite shoulder, and you want to have the elbow out in front of the body somewhat.
Where do you tell them to put the, because a lot of patients will do this.
Yeah, they'll try to have, yeah. And that
So
actually
you
is
want it up
not,
here?
no, I wanted it about, about halfway between the 90-degree point and having it down at their belly. So about like that, and then I'll try to pull the hand off. I shouldn't be able to pull the hand off their opposite shoulder. I don't know if you can see this over there, but so I'm going to try to pull the hand off, and I really shouldn't be able to do that. Okay, so it just stays there.
You can really feel it when you have that resistance. You're not really contracting your pec. You feel it coming down your side here. It's almost like your serratus, but it's really your subscap that's firing to hold it there, which is very helpful. So that's super infra and subscap, and I'll just show you real quickly on Steve. If you do have an infraspinatus tear, then it's worthwhile to test the teres. If you don't have an infraspinatus tear, it's rare that you're going to see a teres minor problem, but you will. We've seen that isolated in terms of atrophy and neurologic injury. But what we do for the teres is, of course, the Hornblower's test, and we hold the arm up in this position here, and if it's working pretty well, they can hold it there, but then when you test the two sides, they can't stop this against resistance. The Hornblower's test is when you put the arm in this position and they have no teres, and it just falls in front of their face, so they're a hornblower, and that tells you the teres minor. And conceptually, what you're thinking about, okay, supraspinatus is not working, infra is not working, how far around the back does this go? And if your teres is out, that changes everything. It changes your results with the reverse. It changes your results in terms of getting strength back with rotator cuff repair. That's a bigger deficit for the way the rotator cuff is functioning. So those are the four muscles of the rotator cuff, and hopefully that exam will help you. Yes, one question. Yeah, the champagne toast I'll show you, and Steve. So what it is, it's just like you're holding a champagne glass. So we probably should have Laurent show us the correct way to hold a champagne glass, which he can do in just a few hours. And you put it in this position here, and then you put the hand over the front of the lower part of the arm, and you ask them to toast, to raise the arm up like that. And in this position here, they don't use very much, just a little of anterior deltoid, but not middle or posterior, but they use their supraspinatus to raise that arm up to initiate that. So it separates out the two a little bit better. All right, thank you very much.